Today, if I had a high-grade lesion in my LAD, I would probably, most probably, get surgery. But I guarantee you, I would demand that it be imaged. Because before the surgeon, as wonderful as they are, tell me that it's fine, I want to see that it's fine. And I think that sort of kernel of communication is what is going to be the tipping point for this Novodec technology in the operating room.
At the end of a procedure, I will go out with a number of images, hard copy images. Hopefully this will be changed in the future and we will have live video that I can show them, live video clips on iPod, for example. And this makes a big difference in how the families understand and appreciate what has been done. Similarly, this is very helpful to show to the cardiologists and referring doctors so they get an image, not just a report of what is happening. It has also been very helpful when there have been changes in the early postoperative period. We can refer back to demonstrating what has been accomplished, and we can actually even compare this to post-operative arteriograms when necessary.
We're able to image in the operating room now, similar to how we image in the cath lab. That allows us to communicate with our referring physicians, to communicate with our other doctors, not surgeons, and most importantly, it gives us the ability to communicate with the patient. The patients need to see, they or their loved ones need to see what we've done in the chest before we've closed it. That is a vital link, and with some of the Novodec technology, I think that's one of the most important currencies that they need to embrace to take coronary artery bypass and its revascularization strategies to the next level. Any little side effects, whether it's bleeding in the cath lab or whether it's inappropriate grafting in the operating room, those are very, very costly. To have a post-operative myocardial infarction, to have a patient that's delayed from getting out of the hospital for 3, 4, 5 additional days is very cost intensive. If we can see before we close the chest that all the intended grafts are doing what they should do, this has a very strong potential to decrease the graft technical issues post-operatively and ultimately provide more cost and effective care to our patients undergoing revascularization. The interventionalists and the surgeons need to work together. This ultimately will yield the most efficient revascularization strategy. And imaging, again, is that common thread of communication between those two disciplines. I need feedback. I am driven by images in the cath lab. Therefore, I want to see, as a spoke of communication from that surgeon, that they have revascularized as we spoke about it before. And I can tell you, because I use angiograms and intravascular ultrasound all the time to communicate to my patients after the procedure, patients like it, enjoy it, and they feel part of the process too. So the interventional cardiologist, the surgeon, and the patient are tied together with this imaging in the operating room.